And I've got the pleasure this week of chairing Report Out. So I'm going to move us straight on to, is it Eliza? Apologies if I pronounced it incorrectly. Yep, is that right?
Elisa.
Eliza, sorry, Eliza. Apologies, Eliza. Increasing falls medication reviews on older people's wards. So we'll go to you and then we'll go straight on from there. Thank you.
Thank you. So I'm one of the pharmacists working in medicines management and pharmacy services. So the problem challenge that we face is certain patients have medications that can increase their risk of falling over. And there was a lack of documented medication review of the fall risk increase in drugs or FRIDs at their cotton for patients admitted to hospital following a fall. There was a variation in practice, documentation and quality of review due to knowledge and time barriers. There was an audit done by the Royal College of Physicians on inpatient falls, which identified LTHT as being a negative outlier for documented medication reviews prior to an inpatient fall. And it links to the 7 C's of care. So sort of making sure patients are receiving care, and then compassion is also involving patients in the decisions relating to their medications. So the aim overall was to complete and document structured medication reviews for falls using shared decision making for all patients admitted to J19 and J21, which are the older people's admission wards, following a fall, who were prescribed at least one fall risk increasing drug. So first completed a stakeholder analysis to sort of look at the different staff that would be involved. So there's the pharmacy team, which I work in, so that comprises of pharmacists, pharmacy technicians, pharmacy support workers. There's the medical team, so there's the consultants, the resident doctors, and then there's the nursing teams as well. So we formulated a standardized template, which we got comments on from the medical teams. So time was one of the barriers. So we embedded the process of listing the falls risk increasing drugs, the ACB score, which is an anticholinergic burden score, which is basically certain medications which can increase patients' risks of falls, and whether they'd had a line and standing blood pressure documented. So we embedded that into the medication history process, which was already a process that our pharmacy technicians complete on admission to hospital. And then that left the review and the plan for the pharmacist to go through with the patient and the medical teams. We did a PDSA cycle after a few weeks where we changed where we documented the reviews from the free text annotation to the clinical notes, because that was in line with how the medical and nursing teams documented their reviews. We also introduced a custom list on PPM to follow up the reviews. We engaged the team overall through teaching sessions, focus groups, peer discussions, and also feedback surveys. So the outcomes, so we got data from 200 patients that we reviewed over 14 weeks that had been admitted to hospital following a fall. 55% of these patients had a change, so that would be a dose reduction, stopping, switching to a safer alternative in the medications that increase their falls risk following the review. We collected a bit of data about readmission rates, and you can see the light orange rate is patients that had not been readmitted following a 2-month follow-up process. And there was the sort of blue is readmitted not due to a fall, purple readmitted with a fall. And we did a survey of pharmacy staff who were completing the reviews. So before the intervention, 0% of pharmacy staff routinely carried out falls medication reviews for patients, and now 75% of the staff surveyed carried out medication reviews always and often for falls patients. And that also showed an increase in the confidence of their ability to carry out the medication reviews as well. So what went well was sort of the collaboration within the pharmacy team, so between the pharmacists and the technician teams, and also between the pharmacy team and the medical and nursing teams. So sort of the documentation that the medical teams could see and respond to, and the nursing teams to sort of prompt them to do line and standing blood pressures on admission and so on. Also encouraging person-centered care using involving patients or their next of kin in the information gathering process about why they were prescribed these medications, and the sort of decision-making processes of changing their medications to ensure that they were fully involved in these changes. And sort of efficient utilisation of resources such as custom lists to keep track of the patients and make sure that we're following up their reviews as well. So using our data collection tool, we got that 74% of patients were involved in the changes made to their fall risk increasing drugs, and that pharmacists were involved in 80% of the changes made to the fall risk increasing drugs. Doing differently next time, I think we could have thought about the sort of quality of the baseline data that we gathered to see how we could think about measuring the improvement that we made from implementing the change, I think in hindsight that could have been thought out a bit better, whereas we sort of went in, sort of made the change, sort of looking at what we knew. The next steps with the project would be to support pharmacy teams working in urgent care rather than just older people's medicine, so such as acute medicine, ED, SDEC, to complete structured medication of falls reviews for patients who are admitted with or at risk of falls, because that compromises quite a large patient cohort in those areas. And also to sort of think about a process for identifying and completing fall medication reviews following an inpatient fall. So this was only for patients that had come in following a fall. Whereas obviously patients can be at risk of falls even if they've come in with different presenting complaints, and it's important that we review their medications following inpatient falls as well. So yeah, thank you.
Thanks so much. I'm going to move on to Clementine, but I've got about 20 questions for you, but hopefully we'll have time at the end, but we'll just move on from there. Okay, thank you so much for that. Shall I go to you, Clementine?
Yes, so I'm the business support manager for research and innovation oncology trials. So could I have the next slide, please? I moved into the business team just over a year ago, and part of my role involves doing invoicing for the oncology team. And I found that this process was very labour intensive and quite slow to get through everything. So I kind of wanted to look at whether we could streamline this process. The oncology portfolio is quite large, about 122 trials at the moment. So we thought, first things first, focus down on one of the sub areas. So we decided to focus on gastrointestinal studies and do a sample of those studies, basically. So we looked at 9 trials within this portfolio out of the 23 trials that they have. And we looked at the number of days taken from the first contact with the sponsor about invoicing via email to the actual day when the invoice was raised, and found that this was an average of 46 days with a range of 5 to 95 days that it was taking. We wanted to reduce this, so we wanted to reduce the time taken to raise an invoice by 50% before April 2025 to tie into that financial commitment that we've got. Next slide, please. So we mapped out the process and identified 2 main barriers. During our first PDSA cycle, we found that sponsor contacts were taking a very long time to respond to emails, and this was actually quite a quick fix. I spoke to the team leader about creating a defined escalation pathway if we were having non-response, and that was really simple. It's just escalating to her, and she's got lots of contacts within the sponsor side that she can escalate and we can resolve it. And also to create an email template which actually outlined our expectations of when we were expecting to hear back. So we said 10 working days, so 2 weeks to hear back, and just outlining that expectation in our initial email, we found that people were responding more quickly. Our second PDSA cycle, I found that quite often our finance trackers that we have, the information there didn't actually match up with the invoice proposals that were being sent by sponsors, or that they were querying the information that we were holding in those finance trackers. I surveyed the study teams to find out about whether they were feeling confident filling out the trackers, and they were actually saying that they felt really confident filling them out. So there was still that mismatch of information. Drilling down into things, talking to the teams, we actually found out that there was a bit of a misunderstanding of how to use the trackers, and that although the business team had given the initial training a few years ago when the trackers had been set up, this training was then being delivered by the study teams, and certain things were just being missed, and there was no official training material to fall back onto. So I created some training material, including presentations, a step-by-step guide to follow, and created drop-in sessions so that people could come and speak to me one-on-one if they had any issues filling those out, and gave some retraining to the GI team. And since then have actually started rolling that out within oncology. Next slide, please. We found that this worked really well. We had really good engagement from the team because they wanted to help sort out the finances. And I look back over those same 9 studies, 5 of which we had invoiced again since that first mini audit that I took, and actually found that the average day had decreased to 14 days with a range of 1 to 29 days. So all of those invoices have been raised within that 1 month of first contact to raising the invoice. Next slide, please. So what went well? We found that the training was really positive, kept us accountable to actually meet the training needs of the team and for the team to fulfill their responsibilities to fill those out as well. Helped us to work a lot more collaboratively rather than just expecting that people knew how to fill out those trackers, actually engaging with them and giving them the support that they need, and then empowering them to feel confident that they could fill those finance trackers out by themselves. Next slide, please. What would we do differently? We found that it worked well on the whole, but obviously it was a very small sample size that we used, but it was what we needed at the time to be able to really fine tune what we were doing within one small group before expanding that out, which we've now done within all of oncology. And then our next steps would be to finish an SOP that we're currently writing to get that process formalized, really keep on top of that training, embed the training within the team, and then look at inefficiencies within the wider process of invoicing, because we really narrowed things down to that first contact to date of invoice raised, and around that there are still some inefficiencies that do need to be streamlined with colleagues. I think that's it. Could I have the next slide? Yeah, that's it. Thank you.
Similarly with yourself, we'll come back to you because I've written down a question, so I've got to write them down, otherwise I forget. So I'll come back to you at the end if that's okay.
Thank you.
Brilliant, thank you. Lucy, I'm hoping you're on the call. Have we got Lucy? No? Okay. It's possible that Lucy didn't realise that she was due to join today. So, oh, she's there. She's just popped up on the screen. Are you there, Lucy?
Yes, I do apologise for being late. Sorry.
It's okay. No, that's okay. No worries. Over to you. If you can catch your breath for a minute, or I can go and ask the questions I've got.
No, that's fantastic.
Okay, straight to you.
That's really good timing. Can I control the slides, or do I have to ask somebody to move it forward for me?
You need to ask them to move it forward for you.
Okay. Yeah. Oh, well, thank you ever so much. And apologies that I was late, but it seems like I've just got here in the nick of time. Hello, my name is Lucy. I'm one of the hepatology consultants, and I work in Jimmy's. And I started my work on the early detection clinic about 18 months ago. The aim of the work here was we had this clinic, but the RTT time was about 9.5 months when I first started on this process. So patients were waiting an awful long time to be assessed and reviewed. And we've managed to get that down to about 2 or 3 weeks now from 9.5 months at the end of the project. So we've had a success, and I'll talk you through how we managed it. And the next slide would be great, please. So this was actually a real success because it's really important. Liver disease is undiagnosed in the communities, and it's really important that we diagnose this so we can offer treatment and try and change the prognosis of this for our patients in Leeds. So this was a success story, having an oversubscribed early detection clinic, but of course patients waiting 9.5 months to be reviewed and assessed by a doctor is far too long, and this fits in really well with our 7 commitments as well. So we'll go on to the next slide. So what did we do? So the first thing, I'd come in as a new consultant at that time, and to be honest, I was a little bit shocked. And the first thing I did was just try and talk to colleagues and understand the issues, understand how long this had been a problem. And then in time, when I established that there was a real appetite from myself and my colleagues to tackle this, I set up a working group, and they are amazing, and without them none of this would have been possible. So managers within the liver unit, the administration team, who are absolutely vital to the process, far more vital than the doctors, and I was one of the lead-in as the consultants working for it. And we use those LIM principles of PDSA, started out initially auditing the patient journey. And that helped to identify the problems that we had along the way. So patients attending and they weren't appropriately fasted for their scan. We initiated things like outcome sheets because some clinics were still happening without clear outcome sheets in the department. I wrote some guidelines so that the pathways were clear. And a lot of these, as a hangover from COVID, a lot of these appointments were done on the telephone. They really ought to have been face-to-face appointments. And we worked that in with a patient coming face-to-face to offer what I call a triple assessment. And we'll come on to that in the next slide, if that's all right. So this was part of the process, and you can see the changes that we've made, and we're working collaboratively with lots of different people, putting in lots of different things. And we brought in this face-to-face triple assessment so that people could come in for a clinic review, have some blood tests, be seen by a hepatology consultant on the day, and also have a FibroScan scan on that day as well. So really, rather than providing that over 2 different appointments or 3, we managed to increase the sensitivity of our diagnosis of liver fibrosis or cirrhosis with fewer visits for our patients, which I think patients themselves have had, there's been positive feedback from. And you can see there in the yellow boxes from the beginning to the end, this sort of approach, rather than toing and froing with repeated prolonged assessments over time, meant that we managed to streamline and structure the clinic. And with all the changes that we've implemented as a whole, we've gone from 9.5 months to an RTT, which was 2 weeks. And the latest figures, I appreciate I was going to present this a few months ago, and the latest figures are also 2 and 3 weeks. We'll go on to that next slide. So what went well, sort of reflecting on the process, I have learned so much throughout this process. I'm enormously grateful for the LIM team, who sort of, you come in with all the enthusiasm and they help to give you the structure in which you can bring about those meaningful changes. And I'm so grateful. I've learned so much through the process. Really amazing colleagues. I think the secret to success in this project really was the rest of the working group. It was the managers that I was working with, the administrators. It was all about them enacting meaningful change, and perhaps me just being a bit of a catalyst for that. And obviously we've seen that meaningful change in our RTT improvement times. And we'll go to our next slide. And what we do differently, I think I came in as a brand new consultant and I wasn't really sure whether I could take it on or whether anybody would be interested in this. And I think going through the formalised LIM process has given me real confidence. And I guess also having a bit of a success has given me confidence as well to try and maybe tackle other problems and give other barriers and things a go. I think the key learning points was getting the right stakeholders on board. That was really, really meaningful in how we could make this change. And I think we have shown now that this change is sustained. It's been sustained since about February this year, but things are constantly evolving and moving, and we need to make sure that our other clinics in the liver department are as successful as this one, and I think that's an ongoing project. And the next slide, if that's all right, I think it's the last one. I just really wanted to include some pictures. This is how we drum up our customers. We go out into supermarkets, into well-being areas, anywhere. We try and target pockets of deprivation in and around Leeds. This van always gets, it has a FibroScan in it and some fantastic members of staff. And I think they get their most positive results when they go to the Houses of Parliament and they scan the politicians. And it's an 100%, I think, target rate there. So I just want to say an enormous thank you. I think that's the last slide, but I can't really remember. I'm so sorry that I was late. I'm really gutted I might have missed the other talks, but happy to take any questions.
They're recorded, Lucy, so you'll be able to catch up, and they're definitely worth catching up on. But I'm really pleased that you were able to join us. I'm going to go. I'm going to open up for any questions. Do you want to drop the slides, and then I can see faces a wee bit better. But are there any questions for any of the speakers today? Just looking. No. Okay. Well, I've got 3. So, well, 3 I've narrowed down to. So I'm going to go in reverse order. Lucy, if I start with you. It did make me smile because early detection clinic, it's a bit of an oxymoron when the wait is 9 months long, isn't it, really, in terms of where you've got to.
Yeah.
I know you said about you know, that you were just the catalyst for that, but I'm trying to think if it's a question or if it is just a stating again what you've said, which is about the individuals, and because there's something about building the belief that things can be different and things can be better rather than this is just how it is. And are you able to just expand on that a little bit in terms of how you were able to? I know you've said about the methodology and how that helped you, but there is something about building a vision around it.
I think you're absolutely right. And I approached a couple of people at first, just sort of asking questions. And I remember I saw one lady in clinic who really stayed with me. There was nothing wrong with her liver. She'd just had one falsely elevated scan, and she'd sat at home so worried for 6 or 7 months waiting. And it really stayed with me, that story. And I thought, we can't let this go on. And a couple of other colleagues actually said, there's nothing you can do in this clinic. Don't even try. And that did delay my process a little bit. And I think that's probably a little bit, we all feel like that sometimes, don't we? And I totally understand that. But it was about, the members of the team that we work with are fantastic. The vast, pretty much everybody comes in day to day to try and have a positive impact and work. And it's just about trying to stick at it in the first few months, which often can be challenging. I have to say it was challenging in this task as well, but trying to stick at it and vibe off each other. And then when we did have some success and we started to see waiting lists fall, really sort of communicating that with the team and demonstrating to them that our hard work was really working in this situation.
I think that probably plays across then to the falls assessment work as well, because when you were talking, I kept thinking to myself, why, yes, why wouldn't we, why wouldn't we do this? Why wouldn't we? We know that falls when they can change of our patients in terms of where their longer term independence and all of those things. And I just wondered from you, and you said about going to acute medicine and some of the A&E and those things, whether or not the level of engagement that you've been able to have with that, and whether or not you feel as though you've been able to, because you're clearly very passionate about it, and the teams that you worked with are clearly very passionate about it, but whether or not you feel as though you've got the support, I suppose, to be able to expand on that further, because to me it seems an absolute, why wouldn't you?
Yeah, I think we're quite blessed in pharmacy that we actually work quite closely with the pharmacy teams in those different areas. Like, we sit in the next office, so I have naturally a good relationship with them anyway. And like the SDEC team, they have the older people's SDEC pharmacy team already, so they've got quite well engaged with the falls. I think it's sort of engaging the pharmacists that sort of the acute medicine patients where they're not as older and frailer, but they do still have high levels of polypharmacy falls, fall risk increasing medications. And when you look at an acute medicine ward, quite a lot of the patients actually come in with falls as well. It's not just the older patients. So I think it's sort of helping people understand that and helping them understand how they can help with the medication reviews and what impact that can have on the patients as well.
And has this not been picked up across the country in terms of, because we've got extensive work that's been undertaken around falls assessment and all of those sorts of things. This hasn't been picked up previously as a standard piece of work that needs to be adopted across, from reconciliation and all of those different things that you want to take.
Yeah, unfortunately, no. Like because I did some work in the community fall service, and when I came back from that, that's when I sort of realised that there's quite varied practice. And actually, in the community, in the fall service, we do very like intensive reviews of their medications. And then I realised actually in hospital we don't have anything similar to that, and we're not really reviewing them. And patients can just get kept on medications that are sort of they might not be perceived by some people to increase risk of falls, but they actually do, such as like antidepressants, ones that you might not typically think might increase the risk of falls. But yeah, I think it's definitely important, and it's in the NICE guidance to sort of make sure that medication review is included in the multifactorial falls risk assessment for patients when they come into hospital as well following a fall.
I really think you should write this up. I really, really think this is something that needs
Yeah,
to, you know,
we presented it. There was the International Conference for Falls and Postural Stability 2 weeks ago in Liverpool. That was the British Geriatric Society. So we had a poster at that. So that was
Right.
good. But I
Brilliant.
think there's definitely lots more work to be done, sort of linking in with maybe the falls teams
Yeah.
and that
Yeah.
kind of thing.
Yeah, I think it's absolutely brilliant. I'm actually in 4 weeks' time. I'm heading to York and Scarborough for a new role, and I've written your name down, and because I want to be in contact with you because it sounds absolutely
Definitely.
superb piece of work, absolutely
Yeah.
superb.
Thank you.
I was just thinking, Clementine, about the invoicing that you've been talking about and the scalability of that, because because it's really, health is a sort of like a team sport, really, isn't it? And making sure all of these different components are working, and that we get paid for what we do, and everything is critical for us to be able to keep doing what we want to do and expand on what we want to do. So it's just really, if you think within your area, I know you've got aspirations to be able to grow it a bit further across oncology, but do you think the approach that you've taken is actually scalable further across the organisation?
So we do use these trackers across all of our trials,
Right.
across the trust. It was just that I was finding this mismatch, and then when you actually dig into it, we found that there was that maybe miscommunication within our teams. So I think the scalability will come from us engaging more with the teams and taking that training to all of the teams. So scaling up the training, I would say.
Right. Okay. And do you feel you've got engagement for that? Because again, coming back to what Lucy was saying, it's that sort of like that building the rolling stone, if you like, in terms of the energy around it.
Definitely. I actually messaged one of the team leaders yesterday to say that since we've had that training, I've noticed that the team has been so engaged.
Brilliant.
Lots of emails asking me to like meet up to go through things together. So I think that willingness is definitely there. They just needed that support from us, from our side.
Brilliant. So I'm just going to, are there any other questions for colleagues at all? No, I'm going to, so 3 very, very different presentations today, but 3 very different contributions to improving the health and the outcomes of the patients that we serve. Phil, just really, really good work. I can't think of a better thing to say. Really, really good work. And thank you ever so much for doing that. And I'm really pleased that you've managed to get you've managed to take so much away from the improvement method, and hopefully that'll support you as you move forward in your careers across the organisation to use that further to solve problems which are everyday occurrences across the trust that we can that we know that we need to address to improve care for our patients. So thank you so much. Really, really good to see you. Take care. Bye.